So good afternoon. I think we already gave time for all of you to join to the session. Thank you for joining us today to this exciting spotlight on science, which will be focused today on hyper and hypocalcemia. As you already know, these are two conditions related to abnormal levels of calcium in the blood, and they are of significant relevance for the endocrinologist because they can impact on various hormonal and metabolic processes or diseases, including chronic liver disease, parathyroid disorders, endocrine tumors, vitamin D, metabolism, etc. So to speak and discuss about this topic, we have two experts in the field who are going to illustrate us about the clinical and scientific aspect of the topic. For me, it's a pleasure to have both of you here in this session. Before starting, I would like to remember all the assistants that we will have time after the two presentations to ask and discuss with the speakers about the topic. So remember that you have the Q&A button at the bottom of the screen, so you can send your questions to the speaker throughout all the presentation, and we will have time to read them after both presentations. So given that said, it is a pleasure for me to introduce Dr. Mikkel Pretorius, who is a senior consultant at Oslo University Hospital with a specialty in endocrinology and internal medicine. He is the head of the osteoporosis and calcium section at this hospital, and clinically works with patients suffering from primary and secondary osteoporosis, as well as with patients with rare bone diseases. He holds a PhD in calcium and bone disorders and is connected to a broad Scandinavian research environment. He is the author of several chapters on the topic in the national guidelines in endocrinology, and has a special interest in primary hyperparathyroidism, in osteogenesis imperfecta, clinical densitometry, osteoporosis in young individuals, and phosphate disorders. He is also a member of the special interest group for calcium and bone disorders of this society. And for all this reason, he is more than prepared, and he has the expertise to talk about the topic that we invited him to speak, that is calcium disorders in endocrinology. So, Michael, when you are ready, the floor is yours.
Thank you very much, Manuel, for such a kind introduction. I will start with just sharing my screen here. I hope you can just give me a hint when it's displaying properly, Manuel. Is it okay?
Yeah, it is perfect now.
Thank you so much. So thank you also to the ESE for hosting these webinars and ESE talks and spotlights sessions. It's really valuable. I have no conflicts of interest. I must admit that I was a bit puzzled when I got this topic. Calcium disorders in endocrinology is really a huge topic, and to try to kind of cover the basis of this in just 30 minutes is quite a challenge. But luckily, we are in 2024. So if you have a challenge either with time or effort, you know that we can always ask our good friends, the AI. And that's why I prepared to collaborate with my friend DALI 3 so that we can make this webinar really clear. I wrote to him in advance and asked him to get us a diagram to show how the calcium physiology and pathophysiology was in the human body. And he's very, very polite. So of course he answers, sure, I'd be happy to help you with this. And just within seconds, I'm presented with this really, really nice figure. It looks fantastic. However, quite early here, you see that there is a lot of problems. You can see here that PTH affects PTH, and you can see that here there is some ovaries and a uterus that is depicted as bone, and it's affecting calcium. It's affecting the kidney, but it looks really very weird. And it also seems that my friend DALI 3 is not really sure of himself, because you can see that it's kind of blurring out the text here. So most of you will probably now think that it's probably because of a bad prompt. Pretorius has to be better at prompting, but I do know something about prompting. You have to be very precise when you are asking the machines how to help you. So I wrote to him again, and I told him that I need a new figure. I need it to be more scientifically correct, maybe in the style of Frank Netter, and I will be using it for a highly educated audience of endocrinologists. So it has to be very precise. And he understands perfectly. He says that, okay, I know what you're seeking. I can give it anatomical precision, attention to details, and a new figure is presented to me within seconds. Again, it looks stunning, but quite early. I hope there are some surgeons here that can concur that this is actually not how the parathyroid gland looks. And in the bottom here, something very weird is going on. The kidneys are affecting the kidneys, and it's again affecting the kidneys, and both of them are affecting the kidneys. I'm also a specialist in internal medicine, and I'm quite sure that this is actually not how the kidneys look. So this is just gibberish. Our research team then did something that today would be regarded as very unmodern. We picked up the telephone and called another human being. Kari Toverud, the only professional medical illustrator in Norway, and we asked her, please, Kari, can you help us with figures explaining both physiology and pathophysiology in this system? And she said, of course. And this is a bit more how I understand this system. PTH increases resorption and formation from the bones. It also increases reabsorption from the kidney. It activates vitamin D through the 1-alpha hydroxylase, which in turn leads to an increased uptake of calcium through the gastrointestinal tract. And this can help maintain a very stable serum calcium. When we are talking about hypercalcemia, we normally divide it into PTH dependent and PTH independent. As most endocrinologists know, the most common PTH dependent reason is primary hyperparathyroidism. In this situation, PTH from, for example, parathyroid adenoma increases bone resorption. It also increases bone formation, but filtration is increased more than reabsorption. So calcium excretion is often high in this disease. And of course, it activates vitamin D, and all of this in sum leads to a chronic hypercalcemia. As clinicians, we often start with asking, is this dangerous? Well, we can go to the Indian PHPT registry to try to find out this. And here we can see there are about 460 patients included. Here we can see that almost none of the patients are asymptomatic. It's old. And they have about 60% of them have bone disease, and 40% of them have renal stone. As many of you will kind of think that many of you will understand, these patients have a quite severe disease with a median calcium of about 3.0. PTH is about 47. And this is really not a very scientifically problematic group. Probably all of these are candidates for parathyroidectomy, for surgery. But in Europe, there is a very different picture. For the last 30 years, we've had a significant increase in incidence here in Europe. Not the same patients as in India, which you can see here by the dotted line. Mainly, it's the increase is in older patients or patients above 50 years of age, and they generally have mild or no symptoms. It's been discussed for a long time how to define this mild or asymptomatic disease, and that's why the first point of order in the 5th international workshop was to refine the definition into asymptomatic PHPT, either with evidence of target organ involvement or without evidence of this. The target organs here are skeletal and renal, and I will show you some data now on what is the problems with these target organs. Of course, skeletal, we are interested in fracture risk, and this is a publication by Lars Reinmark's group, a meta-analysis where they found 8 cross-sectional studies and 4 cohort studies, and they found that these patients actually have an odds ratio of about 2 for any fractures. They also found that they had an increased odds ratio of about 3 for vertebral fracture. Point out that this study is really heterogenic, and you can see here that, for example, one study has a prevalence of vertebral fractures of about 1%, and another study has a prevalence of about 45%. So it's quite different studies in this setting. This has been a problem because if you include both severe and mild disease in this kind of meta-analysis, you will get confused by the results. Luckily, we have 3 randomized control trials with only mild hyperparathyroidism. The first one is the study by Sudhakar Rao with 53 patients and a follow-up of 24 months. The second one is Claudio Marcocci's group with 50 patients and a follow-up of 12 months. And the last one is the SIP trial with 191 patients and 10 years of follow-up. The first 2 are not really designed to look at incidental fractures, but the SIP study published its results in 2022, late 2022, and they found actually that there was very equally the peripheral fractures were very equally distributed in the 2 groups. It did not seem to have a big effect with parathyroidectomy. And the same was with vertebral fractures, 7 and 9 in each group. So no real effect there either. All 3 RCTs measured bone mineral density, and it seems like there is a treatment effect here, both in Rao's study with femoral neck and total hip being significantly better, and also in Claudio Marcocci's group with a significant improvement in lumbar spine and total hip. And last year, Carolina Lundstam published the SIP results, which showed the same, that there is a femoral neck. And also, for the first time, they showed that there was an improvement in distal third of radius, so that there is a treatment effect also here. The long-term effects on kidney function has been published, for example, by Catherine Su with 6,000 patients and 16,000 controls. And here you can see that actually it doesn't seem to have a big effect on decline in estimated GFR, as long as the calcium is not severely elevated. You can see here that only the yellow one with calcium above 3 has an increased decline in estimated GFR. This is also supported by this recent study by Ansgar Heck, which showed the same in the SIP study, that it's really very, that the groups follow each other over a 10-year period, both in creatinine-based estimated GFR and also in cystatin C-based estimated GFR. There really seems to be no real treatment effect in this study. As you would imagine, if you have an effect on both bones, kidneys, and there has also been speculation about other organs being involved here, such as cardiovascular disease and cancers. So over time, you would suspect that this would actually also affect mortality. And there are some studies suggesting this. Among other, this is Clifton Blythe's study, which showed an increased mortality in the hyperparathyroid population compared to Australian background population. The Scandinavian investigation of primary hyperparathyroidism was actually designed to answer this question. The primary endpoint was mortality. There was 191 patients included, and they were randomized to either parathyroidectomy or observation, and it was a predefined observation time of 10 years. This is the main results of the SIP study, and as you can see by the Kaplan-Meier plot, mild disease does not actually seem to affect mortality. There were 7 and 8 deaths in each group after 10 years, and after an even longer observation period of up to 20 years, there were 44 deaths, 20 and 24, with no difference in the two groups. These kind of conflicting results has led to 5 international workshops, and there has also been some differences in the conclusions on which patients should be operated. And as you can see, in general, it seems like the indications for surgery is increasing. And in the last workshop, they concluded that they should lower the calcium threshold for operation from 400 to about 250 milligrams in women. I will not go into primary, secondary, the differences between primary, secondary, and tertiary hyperpara or normocalcemic hyperpara. You can read this beautiful publication by Carlin Sogna in New England. And in about 14 minutes, we will hear lots more about FHH. We also have PTH independent hypercalcemia. Here we have, for example, a PTH RP producing tumor. This is a bit different pathophysiology because now we have an especially increased resorption of the bone. Generally, filtration and reabsorption is more balanced here, but this could be potentially a very devastating disease in terms of the skeleton. We also have the situation with the granuloma and also intoxication. And this is quite different because even though we also here have an increased serum calcium, we now have a low bone turnover, and we can have a quite increased calcium excretion. I would just like to show you this very short clinical vignette from this summer. A healthy young man admitted to a hospital near Oslo with the calcium of 3.04 and creatinine of 210. And I will not go into the differential diagnosis here, but the reason for this is body fuel super strength vitamin D. It's not really that strong, but there has been an error in the production. So it's about 50 times stronger than what is labeled. And now we've had actually 3 patients admitted to Norwegian hospitals because of this body fuel. It's not an exclusively Norwegian preparat, so I'm thinking that some of you have probably also experienced this during the summer. It's out from the market, but it's sold on the internet, so there is a lot of these lying around. If you are working in the ER, you will see this situation. If the patient has a chronic hypercalcemia disease and they get dehydrated or nausea and vomiting, then the kidneys can fail them, and now you will get a quite unstable calcium values. They can be very high, and this is often termed disequilibrium hypercalcemia. Over to hypocalcemia. There are a lot of diagnostic possibilities here, but I would say that for endocrinologists, often we don't actually deal with renal or gastrointestinal disease, And most of the time, the GPs will handle an isolated vitamin D deficiency. So for us, most of the time, we are working in the green fields here with normal magnesium, low or inappropriately low PTH, and normal vitamin D. And then we are in the land of hypoparathyroidism. Kari has helped us with the picture here as well. And here you can see that bone turnover is very low. Reabsorption is low, and that's why there is a high calcium excretion from the urine. And of course, you will not get activated vitamin D. So these patients have a chronic hypocalcemia. There are other electrolyte disorders that are important also in this disease. There is a PTH receptor in the kidney, and this PTH normally here opens this Claudin 1619 channel. So if you have a lack of PTH, then it is closed, and now you will lose magnesium through the urine. You also have a phosphate problem. Normally, NRF1 inhibits the potassium phosphate co-transporters, but if you are lacking PTH, then these co-transporters will open, and now you'll get more phosphate from the urine and back into the blood. It will give you this quite characteristic biochemical profile with low calcium, low PTH, low vitamin D, magnesium, and bone markers, but high phosphate. Only the two first are necessary for the diagnosis. Is this a common disease? Well, these are the reasons for hypoparathyroidism. They all have one thing in common. They are very, very rare, maybe apart from post-surgical, which is about 75% of the disease. This means that the prevalence and also incidence of this disease is highly related to the risk of hypoparathyroidism after thyroidectomy, especially total thyroidectomy. Know this fact. So it means that we have a lot of data in this department. Here I can show you some of the prevalence here. This is a Spanish study with a prevalence of 14.5. A Swedish study with a prevalence following total thyroidectomy of 12.5. UK study 7.3, and American study with a prevalence of 1.9. But before we start blaming the surgeons here, I just want to clarify that all of these studies are using a different definition of hypoparathyroidism. As this has been a recurrent problem within this field, that we have really not a universal definition of the disease. It's still kind of debated if the diagnosis is related to time from surgery, if it's related to treatment, if it's related to laboratory values. And I will just show you an important point here. This is from Villaroya Marquina's group. And if you see just with time, you can see that out of the 142 patients that had hypoparathyroidism, 73 recovered after 6 months, but even after 6 months, 21 more recovered, and even after 1 year, 12 more recovered. So it's really important that we do not give this diagnosis until at least 1 year after surgery, and that the physician that is following these patients has to be aware of this possibility and try to taper the treatment. This has been also a focus group of the second international workshop, and the definition is now quite clear. It's hypocalcemia in the presence of low or inappropriately low PTH, and you should not give this diagnosis until 12 months after surgery. It would lead you to think that you could maybe starting with treatment immediately, but this seems to be not very beneficial. It seems like starting treatment may favor restoration of the parathyroid function, so that you should not wait with treatment, but rather taper it after a while. Conventional treatment is calcium. It's generally absorbed better with meals, and if you follow these patients for a long time, you should be aware that calcium absorption decreases with age. You also give active vitamin D. We've had a lot of drug shortage now in Europe, and I just want to point out that if you change between them, calcitriol is about double the potency, but has a much longer half-life. So it's not really, shorter half-life. So it's not really that uncomplicated to switch between them like we have been forced to do now during the last year. If you have a patient that is treatment resistant, you should always correct hypomagnesemia and maybe also do it in kind of and place the patient in the upper limit of normal. Conventional treatment does not sadly normalize the values in all patients. There are a lot of patients here illustrated like in Deborah Mitchell's study, which are still quite low. These yellow ones are below the reference range most of the time. And you can also see that a lot of these patients are actually also high most of the time. In addition, as you are probably aware, if you are following these patients, many of these are not doing very well. And this is a beautiful study by Tanja Sichar, which compares the hypoparathyroid patients to the hypothyroidism patients. And you can see that they are generally have a much lower quality of life. It's maybe also something to do with structure. And this is a recent publication from May, which show that they have a lower thalamic volume, and also they have a smaller thickness of the hippocampus. So it's an exciting new study in this regard. This has also led us to the possibility of hormone replacement treatment. And the first drug here was teriparatide. It's mainly used in anabolic treatment of osteoporosis, and it has a very short half-life, but it has still been studied as a drug to treat hypoparathyroidism, especially in Karen Wiener's group. As you would expect, it's better with twice daily PTH, and maybe not surprising, if you treat with a pump, then it's maybe better even than twice daily. It's available and affordable, but the very short half-life makes it less than ideal to treat this chronic condition. Since about 9 years ago, we've also had the PTH 184 available. It was approved by FDA and EMA in 2015. It's studied in several well-designed trials, among other the REPLACE trial, which showed that that over 50% of the patients could significantly reduce calcium and vitamin D. It also has the ability to normalize urinary calcium if you let it, if you just give it enough time. This is an extension study. It was available, as many of you, it's still available, but as many of you are aware, it was recalled in the US in 2019 due to rubber particles, and Takeda announced already in 2023 that they will discontinue manufacturing by the end of this year. So this has led to new drugs and new possibilities for them as well. This is the Transcon PTH design. This is PTH 134, given with the Transcon linker that can make this kind of release in a predictable and slow way. And it seems to work. It also has the potential to normalize urinary calcium, which is often quite high in these patients. It is available. It's approved by EMA in December 2023, and it was approved by the FDA in August of 2024. It's studied in well-designed trials, and it seems to be well tolerated. There is a hefty price on this treatment, and there is also some reimbursement issues in many European countries regarding Yorvipath. which is the name. Finally, I would just like to remind people about the PARAT program, an educational program within the ESE. There is a lot of nice educational material here, both in terms of webinars and workshop reports, and also very nice patient education information. So to conclude, primary hyperparathyroidism is a common disease. It seems safe to observe asymptomatic disease without target organ manifestations for at least a decade. Hypoparathyroidism is rare. However, it's not uncommon following total thyroidectomy. The conventional treatment is calcium and active vitamin D, but there are promising developments in hormone replacement therapy. And many of the studies I've shown here today is a result of collaboration across the European borders, and I really think that there is a great potential in this. And finally, I hope that you will agree with me that still in 2024, there is room for a human touch. Of course, I would like to acknowledge all of my scientific research partners in Scandinavia, especially from Oslo and Gothenburg. And thank you very much for your attention.
Thank you so much, Mikkel, for your presentation, for this excellent overview about the clinical implications of these diseases, but also for remind the educational programs of the society to convince us that the human touch is still necessary because of the limitation of the artificial intelligence.